My name is Tom Crabtree and I'm a Diabetes and Endocrinology Registrar and ABCD Clinical Research Fellow working at the Royal Derby Hospital in the East Midlands and Sandwell and West Birmingham Hospitals in Birmingham. I'd like to thank you today for this opportunity to present this analysis from the ABCD semaglutide audit looking at predictors of HbA1c and weight response to semaglutide. These are my disclosures. The ABCD semaglutide audit programme launched in 2018. The aim of this audit programme was to collect anonymised routine clinical data for patients taking injectable semaglutide in order to provide some real-world insights on its use. Data for this audit comes from primary and secondary care via the online audit tool or from primary care via data submitted by clinical commissioning groups on bulk. We know from randomised controlled trials that semaglutide is associated with HbA1c and weight reductions. We observed similar findings in previous analysis in the real world from the ABCD audits. Our earlier work demonstrated that semaglutide was associated with HbA1c reductions of 13.2 millimoles per mole and weight reductions of 4.6 kilograms. We also know from our work in the past that reductions in weight and HbA1c with semaglutide still happened in people who were switched from an alternative GLP-1 receptor agonist to semaglutide, although these were of a smaller magnitude. It should be said, however, that's with the caveat that we weren't able to examine oral semaglutide because we hadn't yet launched the oral semaglutide audit, and also we didn't have data for the newly licensed higher doses of dulaglutide as a comparison. The aim of this analysis was to see which characteristics, perhaps beyond previous GLP-1 receptor agonist exposure, might be able to predict HbA1c and weight reductions with semaglutide, and to do this using a multiple linear regression model. For this analysis, data were extracted from the ABCD audit programme, and the analysis was conducted in Stata 16. For this analysis, missing data were multiply imputed. The study utilised a multiple linear regression model for each of HbA1c and weight change from baseline. Covariates assessed for potential inclusion in the model for statistical significance included concomitant diabetes medications, baseline weight, HbA1c and other measurements, as well as changing these parameters between baseline and follow-up, and those other measurements would include things like blood pressure, ALT levels and EGFR. We also assessed age and duration of diabetes being important recognised factors that might help predict response to therapy. The baseline characteristics of the population included in this analysis are displayed on screen now. Our cohort was followed for a median duration of 0.7 years with an interquartile range of follow-up of 0.4 to 1 years. For reference, the baseline characteristics in Sustain 1 on the 1 mg semaglutide arm are displayed on screen as well. This is a useful reference point because we know that people in real-world studies often have more extreme characteristics than those included in randomised controlled trials. This is useful because these more extreme characteristics are perhaps more compatible with what we would see in a day-to-day diabetes clinic and can give us some reassurance that these results from real-world studies are perhaps generalisable to the people we would be seeing on a day-to-day basis. You can see that the HbA1c in the Sustain 1 randomised controlled trial at baseline was 65.3 millimoles per mole, which is significantly lower than the baseline HbA1c in our cohort, which was 79.5 millimoles per mole at baseline. The weight in Sustain 1 was 96.9 kilograms, and in our study was 107.1 kilograms, and the BMI in Sustain 1 was 33.9, the BMI in our study being 37.1. So definitely more extreme characteristics in our group. Looking at HbA1c and factors that might predict change in HbA1c, we found that greater HbA1c reductions were observed in those with pre-existing metformin use. Smaller HbA1c reductions were observed in those being switched from an alternative GLP-1 receptor agonist, which is consistent with our previous work, but also smaller in those concurrently using SGLT2 inhibitors. We also looked at weight, and we observed that greater weight reductions were found in people who had a higher baseline BMI, which would make sense because there's the concept of perhaps these people having more weight to lose in an absolute sense. But we found that smaller weight reductions were observed in those switching from an alternative GLP-1 receptor agonist, again, this being consistent with our previous real-world work. Bringing this all together, our analysis continues to demonstrate HbA1c and weight reductions associated with the GLP-1 receptor agonist semaglutide. We've demonstrated that in those who've been switched from an alternative GLP-1 receptor agonist to semaglutide, that there are continued HbA1c and weight reductions on switching to the new drug, but that these reductions are reduced compared to those who are GLP-1 receptor agonist naive. This was borne out in this analysis with the HbA1c and weight reductions being attenuated in those with prior GLP-1 receptor agonist exposure. This makes perfectly logical sense because you would expect people having switched from dulaglutide, exenatide, lixisenatide or liraglutide to have had some partial benefit from taking these drugs prior to switching to semaglutide. There is a caveat here, however, because this analysis did not include people taking oral semaglutide, nor did it include people who were taking higher doses of dulaglutide, which are now perhaps more commonly used in clinical practice. This analysis demonstrated that SGLT2 inhibitors attenuated the HbA1c reducing effects of a GLP-1 receptor agonist semaglutide, but the reasons for this aren't 100% clear. In a similar vein, metformin seemed to potentiate the HbA1c reducing effects of semaglutide, and again, the reasons for this aren't certain. It's difficult to draw any concrete conclusions using observational real-world data, but certainly these are two things that we'll need to keep an eye on for further analyses, and hopefully other groups will note this and try to explore it further using their own data sets as well. Finally, we found that those with higher baseline BMI had more absolute weight loss. This is to be expected, as you would expect people with more excess weight to perhaps lose more weight using such a potent treatment, and this finding is certainly comparable with dedicated RCT analysis pulling together data from the SUSTAIN 1 to 5 trials. Thank you for taking the time to listen to this presentation. To learn more about the ABCD audits, you can follow the link on screen now. At the moment, we have several active audits, including the semaglutide audit from which this data is derived. We have sodium glucose link transporter 2 inhibitor audits for dapagliflozin, canagliflozin and empagliflozin that are very active. And we also have several diabetes technology audits, including the Freestyle Libre audit, the Do-It-Yourself Artificial Pancreas System audit, the Closed Loop Insulin Delivery System audit, and this week at Diabetes UK, we're really pleased to be launching the Omnipod audit, which we would welcome you registering for. Again, thank you for taking the time to listen to this presentation, and I welcome any questions that you may have.